There are two things that I think are a little bit problematic. One is to get a clear assessment of what patient has an ECOG performance score 2 and to define more clearly elderly patients. So the definition from what constitutes an ECOG performance score 2 is misleadingly easy. It states that you have complete ability to carry out daily activities of life, but you are less than 50% of the waking hours in bed or chair. So that seems to be a very easy definition. Yet if you ask doctors or caregivers to rate a patient, or you ask the same from patients, then there is a clear difference in that doctors frequently are too optimistic. They will rate patients less easily as a performance score 2 than patients who rate themselves. So the net result of that is that if you look at outcome, doctors are far worse in predicting outcome based on performance score than that patients themselves are. So doctors think that patients with a performance score 2 have a very worse prognosis, but is also due to their own optimism in establishing or ascribing a performance score to a patient. What then happened is that at the early 90s, or late 80s, early 90s, that bad outcome was used as an argument not to treat or give very little treatment to patients with a performance score 2. Now clearly, we need better assessment tools for performance score. And if you apply those rules more strictly, doctors are willing to treat those patients with chemotherapy or combination chemotherapy. So there has been a decline of the use of combination chemotherapy in the late 80s to the mid of the first decade of this century, actually, when either best supportive care or monochemotherapy was the standard of care for patients with a performance score 2. While nowadays, when we have randomized trials comparing single agent chemotherapy to combination chemotherapy, including a platinum agent, the tendency is to use, based on the outcome of these trials, to provide patients with a performance score 2 combination chemotherapy. We all know that somebody who is 75 years of age, relatively fit, not much comorbidity, those factors would favor treatment with chemotherapy or active treatment, while if you have a 95-year-old person who is bedridden for most of the time, you would not apply therapy to. But those crude measurements are actually the only ones we have. Age, comorbidities, or the number of comorbidities, well, there is a lot more. There is fitness, depression, I think, plays a major role in the elderly population, or whether or not to treat those patients. And we simply do not have the tools to really reliably ascribe a certain category to those patients as well. So a lot of research in that respect is needed. In terms of targeted therapies, I think there is a difference, because we know in the right population targeted therapies will have a major effect on outcome. So performance status, age, comorbidities are not that relevant anymore. So if you have a patient, even with a performance score 3 or 4, which means totally bedridden, that has an EGFR mutation or an ALK rearrangement, please treat those patients with an EGFR inhibitor or an ALK inhibitor. And the literature actually suggests that most of these patients will have a major improvement in performance score, simply because the tumor will respond to the therapy and they do not have a lot of side effects. Although data in elderly patients on this subject are by and large lacking, I think the same applies to those patients. If you have an 80-year-old or 85-year-old female or male, for that instance, with an activating mutation that is amenable to therapy, please do so, because those patients certainly will improve in performance status and health status for that matter. The reason why doctors tend, I think, to undertreat patients with a poor performance status or elderly patients is that they fear that the therapy is worse than the disease. In other words, they fear that by the therapy, the deterioration in quality of life will be such that it's simply not worthwhile to treat these patients in the face of the poor prognosis. Literature, however, suggests that when you treat these patients and they will get a response, the magnitude of improvement in quality of life is much more than patients that we actually do routinely treat, that is those patients with a good performance status. So patients with a performance status 2 have much more to gain in terms of quality of life than patients with performance scores or 1. Fear of toxicity is the major driver for undertreatment. And I think this, in these poor performance status patients, and the same more or less is true for elderly patients, because of frequent comorbidity, co-medication, often poor performance status, doctors are afraid that chemotherapy actually induces so much toxicity that that does not outweigh the improvements that you might get from therapy.